Creating a pneumoperitoneum. There are two methods for creation of a pneumoperitoneum, open and closed. The closed method involves blind puncture using a Virus needle. Although this method is fast and relatively safe, there is a small but significant potential for intestinal or vascular injury on introduction of the needle or first trocar. The routine use of the open technique for creating a pneumoperitoneum avoids the morbidity related to a blind puncture. To achieve this, a 1 cm vertical or transverse incision is made at the level of the umbilicus. The umbilicus carries importance as it is a reliable anatomical landmark deriving from the embryological coalescence of the rectus sheath and peritoneum and is devoid of other myofascial planes that could complicate subsequent entry into the peritoneum. Two small retractors are used to dissect bluntly the subcutaneous fat and expose the midline fascia. Two sutures are inserted each side on the midline incision into the rectus sheath confluence, followed by the creation of a 1 cm opening in the fascia. Free penetration into the abdominal cavity is confirmed by the gentle introduction of a finger. Finally, a Hassan trocar or other blunt tip trocar is inserted and anchored with the fascial sutures. This is considered the Hassan or modified Hassan approach. The term modified is used here to denote the same principle as the original Hassan with the midline exposure and access, except that the exact technique has been changed to suit an individual surgeon, such as the adoption of a particular angle of retraction of the umbilicus before an incision into the midline is made to get access to the peritoneum. Rarely a third or combination approach may be employed. Here an open technique is followed with a small then unusual midline incision. Once access to the peritoneum is visualized, a Virus needle is inserted under direct vision and then insufflation is carried out. This small open approach then allows the introduction of a laparoscopic port with view to reducing trauma of the pneumoperitoneum. Such an approach may have benefits for complex cases such as those for redo procedures where the risk of umbilical adhesions during pneumoperitoneum may be high. The open technique may initially appear time consuming and even cumbersome. However, with practice it is quick, efficient and safe overall. Optical entry into the abdomen under direct vision using optical ports, especially in bariatric surgery, is gaining favor with many laparoscopic surgeons. This allows quick and safe entry to the peritoneal cavity using bladeless see-through trocars that allow the different layers to be dissected through using the laparoscope within an optical port to be inserted into the abdomen. Let's see this diagram. This is open technique with Hassan port, applies safe principle of closed technique. Preoperative problems. Previous abdominal surgery. Previous abdominal surgery is no longer a contraindication to the laparoscopic surgery, but preoperative evaluation is necessary to assess the type and location of surgical scars. As mentioned earlier, the open technique for insertion of the first trocar is safer. Before trocar insertion, the introduction of a finger tip helps to ascertain penetration into the peritoneal cavity and also allows adhesions to be gently removed from the entry site. After the tip of the cannula has been introduced, a laparoscope is used as a blunt dissector to tease adhesions gently away and form a tunnel towards the quadrant where the operation is to be carried out. This step is accomplished by a careful pushing and twisting motion under direct vision. With experience, the surgeon learns to differentiate visual between thick adhesions that may contain bowel and should be avoided and thin adhesions that would lead to a window into a free area of the peritoneal cavity. Obesity. Laparoscopic and robotic surgery has proved to be safe and effective in the obese people. In fact, some procedures are less difficult than their open counterparts for the morbidly obese patients, example in bariatric surgery. Technical difficulties occur, however, in obtaining pneumoperitoneum, reaching the operative region adequately and achieving adequate exposure in the presence of an obese colon. Increased thickness of the subcutaneous fat makes insufflation of the abdominal cavity more difficult. With the closed technique, a larger Virus needle is often required for morbidly obese patients. Pulling the skin up for fixation of the soft tissues is better accomplished with towel clamps. Only moderate force should be used to avoid separating the skin farther from the fascia. The needle should be passed at nearly a right angle to the skin and preferably above the umbilicus where the peritoneum is more firmly fixed to the midline. The open technique of inserting a Hassan trocar is easier and safer for obese patients but technically demanding in morbidly obese patients where optical entry is now more commonplace. The main difficulty in reaching the fascia. A larger skin incision 1 to 3 cm starting at the umbilicus and extending superiorly may facilitate this. To reach the operative area adequately, the location of some of the ports has to be modified, and in some instances, larger and longer instruments are necessary. When the length of the laparoscope appears to be insufficient to reach the operative area adequately, the initial midline port should be placed nearer to the operative field. Recently, the use of optical port entry for laparoscopic bariatric surgery has revolutionized port entry for morbid obesity cases. Operative problems: intraoperative perforation of a viscous. Perforation of any viscous such as bowel, solid organs and blood vessels including the aorta is a potential hazard of using the laparoscopic approach, and these complications may be minimized with surgical experience, education, preparation and patient selection. One example in a common laparoscopic procedure such as cholecystectomy includes perforation of the gallbladder. This is more common with the laparoscopic technique than with open technique. Some authors have reported an incidence of up to 30%, but it does not appear to be a factor in increasing their early postoperative morbidity. However, it is well known that bile is not a sterile fluid and bacteria can be present in the absence of cholecystitis. Unless the perforation is small, closure with endoloops and endoclips should be attempted to avoid contamination prior to extraction, which should be with the use of an endovac. Bilious leakage should be suctioned and washed out. If there is stone spillage, every attempt must be made to collect and extract the stones, and if there is a possibility of stones being retained in the peritoneum, then an ultrasound should be arranged 6 weeks post-operatively to assess a collection around a stone, and the patient should be informed of this outcome post-operatively. Antibiotics to manage known sepsis or septicemia in a patient undergoing surgery. Operating on a patient with established septicemia or sepsis is not typically recommended unless the operation will contribute to removing or minimizing infectious origins. Where necessary, pre, peri and post-operative antibiotics should be administered in accordance with local microbiological advice. Antibiotics to prevent infections and sepsis. A single dose of antibiotics should be administered within 1 hour of skin incision in contaminated, semi-contaminated or complex procedures. Additional doses should be administered based on local microbiological advice. Bleeding. In some of the larger series, bleeding has been the most common cause of conversion to an open procedure. Bleeding plays a more important role in laparoscopic surgery because of factors inherent to the technique. These include a limited field that can easily be obscured by relatively small amounts of blood, magnification that makes small arterial bleeding appear to be a significant hemorrhage, and light absorption to obscure the visual field. How to avoid bleeding? As in any surgical procedure, the best way to handle intraoperative bleeding is to prevent it from happening. This can usually be accomplished by identifying patients at risk of bleeding, having a clear understanding of the laparoscopic anatomy, and employing careful surgical technique. Risk factors that predispose to increased bleeding include cirrhosis, inflammatory conditions, acute cholecystitis, diverticulitis, patients on clopidogrel and dipyridamole, coagulation defects. That these are contraindications to a laparoscopic procedure. Bleeding from a major vessel. Damage to a large vessel requires immediate assessment of the magnitude and type of bleeding. When the bleeding vessels is identified, a fine tip grasper can be used to grasp it and apply either electrocautery or a clip, depending on its size. When the vessel is not identified early and a pool of blood forms, compression should be applied immediately with a blunt instrument, a cotton swab, ENT or mastoid swab, or with the adjacent organ. Good suctioning and irrigation are of utmost importance. Once the area has been cleaned, pressure should be released gradually to identify the site of bleeding. Insertion of an extra port may be required to achieve adequate exposure and at the same time to enable the concomitant use of a suction device and an insulated grasper. Although most bleeding vessels can be controlled laparoscopically, judgment should be used in deciding when not to prolong bleeding but to convert to an open procedure at an early stage. Surgicel, absorbable fibrillar oxidized cellulose polymer, or other clot promoting strips, tissue glues or other hemostatic agents may also be used laparoscopically to aid hemostasis. If at any stage bleeding is difficult to stem laparoscopically, there should be no delay in converting to an open procedure in the interest of patient safety. Bleeding from organs encountered during surgery. Intraoperative bleeding from organs can usually be prevented by performing the dissection in the correct plane. As previously mentioned, the common laparoscopic example of a cholecystectomy requires understanding the management of bleeding from the gallbladder bed. When a bleeding site appears during detachment of the gallbladder, The dissection should be carried a little farther to expose the bleeding point adequately. Once this step has been performed, direct application of electrocautery usually controls the bleeding. If bleeding persists, indirect application of electrocautery is useful because it avoids detachment of the formed crust. This procedure is accomplished by applying pressure to the bleeding point with a blunt insulated grasper and then applying electrocoagulation by touching this grasper with a second insulated grasper that is connected to the electrocautery device. One must be careful to keep all conducting surfaces of the grasper within the visual field while applying the electrocautery current. Bleeding from trocar site. Bleeding from the trocar site is usually controlled by applying upwards and lateral pressure with the trocar itself. Considerable bleeding may occur if the falciform ligament is impaled with the substernal trocar or if one of the epigastric vessels is injured. If significant continuous bleeding from the falciform ligament occurs, hemostasis is achieved by percutaneously inserting a large straight needle at one side of the ligament. A monofilament suture attached to the needle is passed into the abdominal cavity and the needle is exited at the other side of the ligament using a grasper. The loop is suspended and compression is achieved. Maintaining compression throughout the procedure usually suffices. After the procedure has been completed, the loop is removed under direct laparoscopic visualization to ensure complete hemostasis. When significant continuous bleeding from the abdominal wall occurs, hemostasis can be accomplished either by pressure or by suturing the bleeding site. Pressure can be applied using a Foley's balloon catheter. The catheter is introduced into the abdominal cavity through the bleeding trocar site wound. The balloon is inflated and the traction is placed on the catheter, which is bolstered in place to keep it under tension. The catheter is left in situ for 24 hours and then removed. Although this method is successful in achieving hemostasis, the authors favor direct suturing of the bleeding vessels. This maneuver is accomplished by extending the skin incision by 3 mm on both sides of the bleeding trocar site wound. Two figure of 8 sutures are placed in the path of the vessel at both ends of the wound. Devices such as endoclose may also be used to apply transabdominal sutures under direct laparoscopic view to close port sites that bleed. Evacuation of blood clots. The best way of dealing with blood clots is to avoid them. As mentioned, careful dissection and identification of cystic arteries and its branches, as well as identifying and carrying out dissection of the gallbladder in the correct plane, help to prevent bleeding from the cystic vessels and the hepatic bed. Nevertheless, clot formation takes place when unsuspected bleeding occurs or when inflammation is severe and a clear plane is not present between the gallbladder and the hepatic bed. The routine use of 5,000-7,000 units of heparin per liter of irrigation fluid helps to avoid the formation of clots. When extra bleeding is foreseen, a small pool of irrigation fluid can be kept in the operative field to prevent clot formation. After clots are formed, a large bore suction device should be used for their retrieval. Care should be taken to avoid suctioning in proximity to placed clips. Here there is management of bleeding done from a surgical trocar using the suture. Principles of electrosurgery during laparoscopic surgery. Electrosurgical injuries during laparoscopy are potentially serious. The vast majority occurs following the use of monopolar diathermy. The overall incidence in between 1 and 2 cases per 1000 operations. Electrical injuries are usually unrecognized at the time that they occur, and patients commonly present 3 to 7 days after injury with complaints of fever and abdominal pain, as these injuries usually present late. The reasons for their occurrence are largely speculative. The main theories are: first, inadvertent touching or grasping of tissue during current application. Second, direct coupling between a portion of bowel and a metal instrument that is touching the activated probe. So it's given over here. Direct coupling between bowel and laparoscope which is touching the activated probe, you can see. Third, insulation breaks in the electrodes, direct sparking to bowel from the diathermy probe. Fifth, current passage to the bowel from recently coagulated electrically isolated tissue. Bipolar diathermy is safer and should be used in preference to monopolar diathermy, especially in anatomically crowded areas. If monopolar diathermy is to be used, important safety measures include attainment of a perfect visual image, avoiding excessive current application, and meticulous attention to insulation. Alternative methods of performing dissection, such as the use of ultrasonic devices, may improve safety. Post-operative care. The post-operative care of patients after laparoscopic surgery is generally straightforward with a low incidence of pain or other problems. The most common routine post-operative symptoms are a dull upper abdominal pain, nausea, and pain around the shoulders referred from the diaphragm. There has been some suggestions that the installation of local anesthetic to the operating site and into the suprahepatic space, or even leaving 1 liter of normal saline in the peritoneum, serves to decrease post-operative pain. It is a good general rule that if the patient develops a fever or tachycardia or complains of severe pain at the operation site, something is wrong and close observation is necessary. In this case, routine investigation should include a full blood count, C-reactive protein measurement, liver function test, an amylase test, and probably an ultrasound scan of the upper abdomen to detect fluid collections. If bile duct leakage is suspected, endoscopic retrograde cholangiopancreatography may be needed. If in doubt, relaparoscopy or laparotomy should be performed earlier rather than later. Death following technical errors in laparoscopic cholecystectomy has often been associated with a long delay in deciding to re-explore the abdomen. In the absence of problems, patients should be fit for discharge within 24 hours. They should be given instructions to telephone the unit or their general practitioner and to return to the hospital if they are not making satisfactory progress. Nausea. About half of the patients experience some degree of nausea after laparoscopic surgery, and rarely this may be severe. It usually responds to an antiemetic such as ondansetron and settles within 12 to 24 hours. It is made worse by opiate analgesics, and these should be avoided. Shoulder tip pain. The patient should be warned about this preoperatively and told that the pain is referred from diaphragm and not due to a local problem in the shoulders. It can be at its worst 24 hours after the operation. It usually settles within 2 to 3 days and is relieved by simple analgesics such as paracetamol. Abdominal pain. Pain in one or other of the port site wounds is not uncommon and is worse if there is hematoma formation. It usually settles very rapidly. Increasing pain after 2 to 3 days may be a sign of infection, and with concomitant signs, antibiotic therapy is occasionally required. Occasionally, herniation through a port may account for localized pain, and this can sometimes be due to Richter's hernia, such that the patient exhibits no sign of intestinal obstruction. Successful laparoscopic surgery should not cause a patient increasing or undue pain. If there are any clinical concerns post-operatively due to worsening pain, tachycardia or pyrexia, senior review with a view to imaging or increasingly commonly relaparoscopy should be considered. Analgesia. A 100 mg diclofenac suppository may be given at the time of the operation. If this medication is not contraindicated, it is important that the patient provides separate consent for this if the suppository is to be administered per-operatively. Suppositories may be administered a further 2 to 3 times post-operatively for relief of more severe pain. Otherwise, 500 to 1000 mg of paracetamol 4 hourly usually suffices orally, or if more pain, intravenously. Opiate analgesics cause nausea and should be avoided unless the pain is very severe. In this case, suspect a post-operative complication as above. The majority of patients require between 1 and 4 doses of 1 gram of paracetamol post-operatively. Severe pain after routine laparoscopic cases should warn the clinician that there may be an iatrogenic or surgical cause of this pain that may need further investigation with blood tests, imaging, and even relaparoscopy. Orogastric tube. An orogastric tube may be placed during the operation if the stomach is distended and obscuring the view. It is not necessary in all cases. It should be removed as soon as the operation is over and before the patient regains consciousness. This is more routinely used in bariatrics and esophagogastric surgery, where a larger 32 French or 34 French tube is used. Oral fluids. There is no significant ileus after laparoscopic surgery except in resectional procedures such as colectomy or small bowel resections. Patients can start taking oral fluids as soon as they are conscious. They usually do so 4 to 6 hours after the end of the operation. Oral feeding. Provided that the patient has an appetite, a light meal can be taken 4 to 6 hours after the operation. Some patients remain silent, slightly nauseated at this stage, but almost all eat a normal breakfast on the morning after the operation. Patients will require advice about what they can eat at home. They should be told that they can eat a normal diet but should avoid excess. It seems sensible to avoid high-fat meals for the first week, although there is no clear evidence that this is necessary. Urinary catheter, it depends on the operation. If a urinary catheter has been placed in the bladder during an operation with likely short stay, it should be removed before the patient regains consciousness. If the procedure has proceeded well, the patient should be warned of the possibility and symptoms of post-operative cystitis and told to ask advice in the unlikely event of this occurring. Drains. The use of post-operative drains in laparoscopic patients depends on the operation performed. Drains are used to assess post-operative blood loss if this is a clinical concern, or to assess the nature of intraperitoneal fluids, depending on procedure and post-operative monitoring needs. Some surgeons drain the abdomen at the end of laparoscopic cholecystectomy, although this is controversial. If a drain is placed to vent the remaining gas and peritoneal fluid, it should be removed within 1 hour of the operation. If it has been placed because of excessive hepatic bleeding or bile leakage, it should be removed when that problem has resolved. Usually after 12 to 24 hours, continued blood loss from a drain is an indication for re-exploration of the abdomen. Surgical principles: meticulous care in the creation of a pneumoperitoneum, controlled dissection of adhesions, adequate exposure of operative field, avoidance and control of bleeding, avoidance of organ injury, avoidance of diathermy damage, vigilance is in the post-operative period. Discharge from hospital. Patient discharge is based on clinical indicators and their fitness for recuperating in a non-hospital environment. One of the core drivers for the application of minimally invasive surgery is an early recovery and therefore discharge from hospital. For the common laparoscopic procedure of cholecystectomy, most surgeons discharge a significant proportion of their laparoscopic cholecystectomy patients on the day of the surgery, but some are kept in overnight and discharged the following morning. Patients should not be discharged until they are seen to be comfortable, have passed urine and are eating and drinking satisfactorily. They should be told that if they develop abdominal pain and other severe symptoms, they should return to the hospital or to their general practitioner. Even for more major cases, including procedures such as laparoscopic anterior resection, some units have demonstrated a safe and feasible protocol for a 23-hour stay. Skin sutures. If non-absorbable sutures or skin staples have been used, they can be removed from the both sides after 7 days. Mobility and convalescence. Patients can get out of bed to go to the toilet as soon as they have recovered from the anesthetic and then should be encouraged to do so. Such movements are remarkably pain-free when compared with the mobility achieved after an open operation. Similarly, patients can cough actively and clean bronchial secretion, and this helps to diminish the incidence of chest infections. Many patients are able to walk out of the hospital on the evening of the operation, and almost all are fully mobile by the following morning. Thereafter, the post-operative recovery is variable. Some patients prefer to take things quietly for the first 2 to 3 days, interspersing increasing exercise with rest. After the third day, patients will have undertaken increasing amounts of activity. The average return to work is about 10 days. The principles of common laparoscopic procedures. The principles of common laparoscopic procedures are described in the appropriate chapters. Laparoscopic cholecystectomy, laparoscopic inguinal hernia repair, laparoscopic anti-reflux surgery, laparoscopic appendicectomy, laparoscopic bariatric surgery, laparoscopic colectomy or anterior resection, laparoscopic upper gastrointestinal surgery. Other elective minimal invasive laparoscopic, thoracoscopic or robotic procedures that are now widely utilized in certain specialty centers include colectomy, gastrectomy, splenectomy, nephrectomy, adrenalectomy, prostatectomy, typically robotic, thyroid and parathyroid surgery, aortic aneurysm surgery, single vessel coronary artery bypass surgery, video assisted thoracoscopic surgery, laparoscopic hernia surgery, inguinal, femoral, paraumbilical, incisional. Laparoscopy has also been used in certain emergency situations in stable patients in the hands of experienced laparoscopic surgeons. These include laparoscopic appendicectomy, typically the most common minimal invasive emergency procedure, repair of a perforated duodenal ulcer, laparoscopic cholecystectomy in severe cholecystitis, so-called hot cholecystectomy, and treatment of intestinal obstruction secondary to adhesions, strangulated hernia repairs, and also the laparoscopic evaluation of stable trauma patients. Procedures that have been carried out using robotically assisted minimal invasive surgery include all of those listed above. Currently, robotic surgery still has certain disadvantages: increased cost, increased setup of the system and operating time, socioeconomic implications, significant risk of conversion to conventional techniques, prolonged learning curve, Multiple repositioning of the arms can cause trauma, hemostasis, collision of the robotic arms in extreme positions. Until these are overcome by continued development of the technology and the drive of surgeons to progress in the field, robotically assisted surgery will not be commonplace. However, the potential for such systems is immense, and continued research and clinical trials will pave the way for future generations of surgeons and patients alike. Further developments that have made minimal invasive surgery even less invasive: single incision laparoscopic surgery. Laparoscopy has reduced the trauma from surgery compared with open techniques and now is used routinely for benign and oncological surgery in many centers. However, there is continued work on how to reduce the trauma and scarring from the incisions used in laparoscopic surgery because multiple port sites are needed for most procedures. Natural orifice transluminal endoscopic surgery, notes, see below, addresses this, but at present the safety of the transgastric route is not sufficient for the routine use of this approach to surgery. Advanced laparoscopists have therefore turned to focusing on the single incision for opening entry via the umbilicus as an alternative. Single incision laparoscopic surgery (SILS) is a technique adopted by some surgeons to insert all the instrumentation via a single incision through a multiple channel port via the umbilicus to carry out the procedure. The benefit is that the only one incision through a natural scar the umbilicus is made, therefore these procedures are virtually scarless. Second, the use of fewer port sites around the abdomen gives the potential for less pain, less risk of port site bleeding, and reduced incidence of port site hernia. This technique has many other synonyms, including laparoendoscopic single site surgery (LESS) and single port access (SPA) surgery, among many others. Although SILS has gained the most recognition, it does require specially manufactured multi-channel ports and often roticulating instruments. There has been an explosion of activities in SILS procedure in the last few years, and in some units, laparoscopic cholecystectomies and hernias are routinely started as SILS cases. The clinical benefit and cost effectiveness of this technique, which has a difficult and steep learning curve and specific instrument requirements, remain under review. Although it has been adopted as a routine approach for some procedures in some units, early evidence understandably demonstrated better cosmetic outcome and less pain in the immediate post-operative period. However, this needs to be further corroborated with higher levels of evidence with longer term follow-up results, specifically because the SILS approach was not designed for improving clinical outcomes when compared with standard minimally invasive approaches, and improvements in pain and cosmesis between SILS and standard minimally invasive approaches require further elucidation. Natural orifice transluminal endoscopic surgery, notes, this technique whereby surgeons enter the peritoneal cavity via endoscopic puncture of hollow viscus has been much publicized in recent years. The notes approach has been utilized in nearly every body system and operative specialty addressing the pelvis, abdomen and thorax. Worldwide adoption rates compared to standard open and minimal invasive approach remain very low. Transvaginal nodes cholecystectomies have been performed in humans successfully. Although hybrid procedures, joint laparoscopy and nodes, are still employed regularly for safety reasons, the closure of the visceral puncture site is the issue that has prevented widespread uptake of this technique, as transgastric and transcolonic closure of peritoneal entry sites is a routinely safe way remains unperfected for general use. Also, the equipment needed has significant cost and training needs, including surgeons and a large variety of ancillary team members that range from scrub nurses to anesthetists and require a large number of practitioners in the team at present. Nevertheless, it has much promise to be a technique for truly scarless surgery in the future, and much research continues in this field, which is less widely adopted at present than SILS. The future. Although there is no doubt that minimal access surgery has changed the practice of surgeons, it has not changed the nature of disease. The basic principles of good surgery still apply, including appropriate case selection, excellent exposure, adequate retraction, and a high level of technical expertise. If a procedure makes no sense with conventional access, it will make no sense with laparoscopic approach. Laparoscopic and robotic surgery training is key to allow the specialty to progress. The pioneer of yesterday have to teach the surgeons of tomorrow not only the technical and dexterous skills required, but also the decision making and innovative skills necessary for the field to continue to evolve. Training is often perceived as difficult as trainers have less control over the trainees at the time of surgery and caseloads may be smaller, especially in centers where laparoscopic and robotic procedures are not common. However, trainees now rightly expect exposure to these procedures, and training systems should be adaptable for international exposures so that these techniques can be disseminated worldwide. The predominant video and digital component of these new techniques opens the door for simulation approaches for training in these modalities, which has demonstrated benefit in reducing learning curves and in turn is aimed at improving patient outcomes. The ultimate goal for this educational approach is to develop expert surgeons through the total safe and risk-free environment of simulation before they actually have to operate on patients. The current status for laparoscopic trainees reflects their decreased experience in open approaches so that they feel less comfortable converting cases such as laparoscopic cholecystectomies to open cases. It is important that the straight to minimal invasive trainees continue to have training in open skills so that they can apply both approaches where necessary. Improvements in instrumentation, the continued progress of robotic surgery, and the development of structured training programs are key to the future of minimal access surgery. The use of robots in surgery has increased dramatically in the last decade. Indeed, robots are now available not only for assisting in surgery but also for aiding in the perioperative management of surgical patients. The remote presence systems allow clinicians to assess patients in real time and interact with them while they are not on site or even on a different continent. Applying established devices in different contexts also offers the introduction of innovation. For example, the label procedure, laser assisted bile duct exploration by laparoendoscopy for choledocholithiasis, was developed when the concept of laser stone management in urology was applied to laparoscopic biliary tree surgery. Continued advances in related technologies such as computer science will allow the incorporation of augmented reality systems alongside robotic systems to enhance surgical precision in image-guided surgery. Endoluminal robotic surgery remains in its infancy, but systems are being developed that will enable navigation within the colon to allow surgery on lesions in spaces that are accessible from the outside without an exterior incision being made. The advent of nanotechnology should also bring about much changes in surgery. Miniaturization may be possible, potentially allowing surgery at a cellular level to be carried out. At present, work has already started on single port laparoscopy. See above under single incision laparoscopic surgery, in which a single port may act as a camera and have unfolding instruments that open up once they are inside the peritoneum to perform the surgery, therefore reducing the number of port sites needed. Extensive research is also being carried out in the fields of nodes, minimizing the potential contamination of the peritoneum and the ability to carry out a safe closure of the peritoneal entry site are the main technical challenges of this type of minimal invasive and essentially scarless or incisionless surgery. It is certain that there is much that is new in minimal access surgery. Only time will tell how much of what is new is truly better. Specifically, the future evolution of robotic systems include full integration with next generation technologies such as advanced augmented reality, autobionics, neuromorphic visual processing, and real-time diagnostic and therapeutic exemplified by the iKnife real-time tissue metabolic profiling and tissue level diagnosis developed by Zoltan Takats and Imperial College London. Large master slave constructions with multiple arms are likely to give a way to flexible access bio-inspired fab systems. These will probably offer full robotic arm articulation and much more portable devices with low energy needs. They would be totally modular with integrated imaging and would have platforms to offer multi-purpose usage of increased utilization and cost efficiency. These systems would also result in a smaller physical footprint with cheaper devices offering more utility, precision and dexterity on platforms that allow both master-slave and direct functionality. One major obstacle in minimal invasive technology includes the Achilles heel of cost efficiency and device financing in an increasingly rationed global healthcare environment. This is an issue which will require surgical liaison with hospital management and national policy providers. Surgeons need to continue to have a dialogue discussing their experiences and ideas regarding all the minimal invasive approaches. None of these techniques needs to exist in isolation. The future can offer a hybridization of these approaches, including a vast array of possibilities such as robotic cells, robotic nodes, or even endoscopic nodes, augmented cells, endoscope pass through a cell port. Such cross fertilization can offer new innovation and techniques, thus harvesting the advantages of new approach procedures and discarding the individual weakness of others can ultimately improve patient outcomes and results. The cleaner and gentler the act of operation, the less the patient suffers. The smoother and quicker his convalescence, the more exquisite his healed wound, said by Berkeley George Andrew Moynihan in 1920.